Everyone, my name is Jason Crosby with Strategic Healthcare Partners. I'd like to thank you for attending our presentation today on best practice analytics in today's physician practice setting. Our goal in this presentation is to illustrate real-life scenarios that are taking place in everyone's practices and how our analytic services and platform has helped with the necessary solution and action plan for such cases. Hopefully you all will walk away with how such a combination of technology and will support specific market knowledge can help your practice grow as well as make your job easier and more streamlined. After a brief introduction, Jose Valero with Dashboard MD will walk you through the clinical module. We'll then break for a couple of minutes to answer questions in the middle of the presentation and wrap up with questions as well. For housekeeping purposes, everyone's lines are muted, so if you have any questions or issues with the presentation, please type them in the GoToMeeting chat box. We will address them and follow up accordingly. With all of that said, let me make a pre-introduction. So who are we? Strategic Healthcare Partners, SHP. We're a consulting firm founded just over 10 years ago, focused on managed care contracting, provider enrollment, data analytics, IPA management, and clinically integrated networks. Most of our staff comes from a provider background and have worked down in the trenches, and just as most of you are doing today. So we have, in some form or fashion, felt your pain. Using our web tool powered by Dashboard MD, we can provide your practice with an easier way to access the information as well as data. Together, we can use high-level dashboards to identify areas that require attention, then dive down to gain a deeper understanding of the issue. Familiar with most major practice management systems, and of course, never afraid to learn new ones. So that way, we can get the most out of your data. So now, let's get in the weeds, and with that, I'll hand things off to our presenter today, Jose.
Well, thank you, Jason. All right, well, we've got a lot to cover, so I'll jump right in the interest of time. First and foremost, let me log into the application here, and as I do, I'll give you guys a quick introduction as to what we're going to focus on here. The application, of course, is a website. I'm logging in directly to the population health module. And let me start by saying a little bit about population health. In fact, I'll just go right there. You know, population health is really built around effectively identifying specific patients and more so groups of patients or populations, if you will, that may require certainly some specific care management, maybe just being identified, being bubbled to the top, as we say. A typical example, of course, might be patients with chronic conditions or multiple chronic conditions with specific test results or vitals or findings, or just plain inactivity. So with that in mind, our application does a great job of managing gaps in care, which is a key component of effective population management, clinical quality measure optimization. A lot of this is summarized with these clinical quality measures we'll be diving into today. And of course, the ad hoc clinical population queries, which I'll talk about as well, being able to dive into the data and pull up patients by a number of clinical criteria. So let's start with the clinical quality management, CQM, or gaps in care management, rather. So these CQMs are, for those of you that are familiar with these and that have wrestled with these, can appreciate the complexity behind these, but in a simple sense, what we're trying to do is track a particular care process or a particular outcome. In the case of diabetes A1C poor control, that's an outcomes measure. We're really highlighting patients that are in poor control of their A1C lab results. In the case of controlling high blood pressure, another outcomes measure, we're tracking patients that have good control for their blood pressure. Others are more of a process, perhaps annual wellness visit follow-up, for example. It's really just a process, getting them in there and seeing these patients on a regular basis. We can break out these measures into measure groups, maybe targeting a particular care plan or a particular payer program, such as MIPS, of course. But in the end, tracking these clinical quality measures manually is quite challenging and certainly error-prone and laborious, right? So with a system like this, what you can do is, first of all, see how you're performing. And let's say we take controlling high blood pressure, which is a pretty easy one to digest and understand. And we can see how the practice is performing as a whole, or we can dive into that particular measure and see the results of the corresponding patient population. Of course, you start with the denominator or the initial population. Those are all the patients that meet the criteria. In this case, just to sort of show off the measure logic a little bit, they've got to be above the age of 18 or within the ages of 18 and 85. They have to have had a visit within a year and essential hypertension as a diagnosis. Within those, we want to look at those that have a blood pressure reading of 140/90 or better than 140/90 to be exact. So the system can identify patients by attributed physician. So I can bubble to the top Dr. Rowley here, who has the lion's share of the patients that we're managing for hypertension. And she's actually doing a good job. And I can quickly isolate the numerator outliers, those patients that have either not been in the office within our expected time frame, or the last time they were here, last time we recorded a blood pressure reading, it was above 140/90. And you could see right away the the last blood pressure reading, and even if they have an appointment, which brings us to the workflow. So the idea is sort of twofold. Number one is to identify those patients that we need to bring into the office. So I can quickly isolate patients that have no appointment scheduled, that we don't even know when we're going to see them again. And for outreach purposes, this makes it easy for me to export this to Excel, and I can build from there. In addition, I can also, let me just mention that we can also bring in more information like patient phone number, of course, race, ethnicity, zip code, all sorts of additional information that might be helpful for outreach, and we can track patient notes. Now, let's take it one step further. What if we want to highlight patients that are coming in today? Here's a patient that's coming in today that we just need a good blood pressure reading. And then I can do that for all the physicians. I can toggle between them and see, based on today's patients that need to get a good blood pressure reading, how quickly I can isolate those. And I'm doing that with the data very quickly. I'm literally clicking through it, and I can see how these providers are performing for this measure. So this helps us optimize this clinical quality measure result. The thinking being, in a simple sense, good blood pressure reading. When they walk out of the office and the data is processed, we literally move the needle a little bit. And as all the doctors sort of pile in, eventually we'll cross our goals and continue to improve. The end result, of course, is a performance of this performance improvement initiative might be an improvement in payer model or improvement in reimbursements, and certainly clinical quality improvement. Now, to add to that, now that we've got the measures detailed out and we can drill down into the patient population, I'm also going to break this out a couple different ways to make it a little easier to manage, especially a larger organization. So the first thing the first 30,000-foot view would be to break out these measures by specialty. And if I scroll down here, I've got all the measures turned on here. Here's my controlling high blood pressure, and I could see of all my specialists the number of patients they have attributed to them and how many have actually met the target. So I might want to dive into my internal medicine group, and the system's going to give me a comparative dashboard showing how each of the internal medicine physicians is doing relative to their goals. And I can bubble to the top the ones that are doing quite well. And in fact, you'll notice there's Dr. Johnson here who only has one patient, so maybe I actually want to bubble to the top the ones with the most patients. To continue this, I can certainly drill down on a physician and see how they're performing across all the measures that are assigned to them. And of course, these provider dashboards, if you will, I'm just sorting it by percent of goal to bubble to the top. the ones that have the most action here. And as I was saying, you can also provide the doctors with access to these dashboards, or you can provide them an email type dashboard report that might give them a summary on a monthly basis, perhaps, maybe even weekly in some cases, but a summary of their results for these clinical quality measures, and maybe even combine it with some other more traditional productivity measures like visit counts and so on. So the next step is to go in here and take a look at how each doctor is doing, or the big picture of all the doctors per specialty. And you can see how the doctors are doing, how many measures met the target, how many haven't. Lastly, you can see how the specialty as a whole is doing, and you can certainly drill down on any of these as well. So as this one finishes rendering, the idea is to quickly assess, your performance with regards to these clinical quality measures, and whether they tie back to a particular payer program or just an internal performance improvement initiative. A tool like this is invaluable, truly, to be able to manage all those moving parts and be able to quickly summarize performance across the board. So let me pause right there before I go into the ad hoc clinical population piece. We're going to talk a little bit about that in just a second. Let me turn it back over to Jason and see if there are any questions.
Yeah, thank you, Jose. We do have a couple questions to throw out there. Our practice is composed of a few different offices and EMRs. Can you link them up together?
Oh yeah, great question, and actually a scenario that seems to be popping up more often. Yeah, absolutely. What's underlying is an enterprise data warehouse, if you will. It's integrated with financial information, operational information, for example, the scheduling, looking at appointments and how they tie back, and of course all the clinical data, including medications, active medications, lab test results, vitals and findings, and so on. So yeah, absolutely.
Excellent, excellent. Our next one: how does the attributing provider get set among multiple practices that are connected?
Really, another good question, and something that comes up pretty often. So there's a pretty straightforward formula, and the way it goes is like this: you take the patient and you attribute the patient to the provider that they most see, but you do it per specialty. So, for example, if a patient sees their primary care physician twice in 1 year, but maybe they're working with a cardiologist or an OBGYN or some other specialist on a particular problem, they may see them 3, 4, 5 times that year. So the patient's actually attributed to both, but with regards to the measures that the primary care physician is tracking, the patient's of course attributed accordingly, and same goes for the specialist. So you don't miss out on these patients, you certainly don't miss out on the visits, and it's really designed to make the most of the patient visits, whether they're seeing a specialist in the network or the primary care.
Fantastic, fantastic. Okay, let's go ahead and get back to the presentation, and everyone, please remember, if you have any questions, please type them in the chat box, and we'll answer those at the end. All right, Jose, hand it over back to you.
All right, good deal. So this part of it is really a little bit more free-form, and just to sort of bring it to earth, bring it down to earth, as I like to say, it's about being able to leverage all of that clinical, integrated clinical information to pull up patient populations, patients that meet certain criteria or don't meet others, or any combination therein. I'll give you a couple of quick examples. I try to keep it pretty simple. So you've got the ability to create these patient registries, if you will. Really, they're just report groupings or population groupings, and then you've got these population queries, as we think of them, or reports. Think of them as a patient list. And I do a lot of work here with adult diabetes, so I've got all these different breakouts of my diabetic patients. Now I could start with, let's say, all diabetic patients, and maybe we'll start there. That's a query that basically just says, give me all the patients that have a diagnosis of diabetes. So I've got something in the order of 1,300 or so patients that we're managing across a bunch of different doctors here. And of course I can list those, and everything else is still in play. I can flag which ones have an appointment and so on. But what really makes this interesting is as I go back to this, I say, well, you know what, I actually want, and I've already created a few of these. I want diabetics with asthma. So the way this works, let me give you a little peek behind the curtain here, is you can add all sorts of clinical criteria. In this example, I've got one called diabetics with asthma, and one of the criteria is that they have diabetes, and I can go over here and look at the diagnosis, condition, or problem, and I want to go ahead and select an active diagnosis, and I'll come down here and pick asthma, and as well as diabetes. And what the system does is it manages all of these different coding schemes, taxonomies, if you will, and the sets therein. So these are all the codes for diabetes, and we've got the similar codes for asthma. And so by combining those two, now I can say, okay, give me those patients. And it shortens the set. I think we had about 1,300 diabetics we were managing. And so now I've got 284 patients that are diabetic and have asthma. And as you would expect, you can go back and maybe even shorten the set even further. Here I've got one for diabetics with asthma and hypertension. Let's take a look at that, see what results we got. So we went somewhere from 1,300 to maybe 80-something or 280-something. I forget the number, forgive me, to 79. And what we're doing is really honing in that set, and you can continue that, and you can get even a little bit more detailed. Again, just to show you one more example, you can go in there and add maybe encounter activity or the lack thereof. If I wanted to say, okay, folks that had a face-to-face encounter or office visit and maybe did not have, so not having office visit within 2 years, let's say, of the measure end date. And that measure end date could be this year, last year, it depends on when you're creating these queries. But by adding these sort of extra criteria, there's all sorts of information you can include. You can include specific medications, active, that were administered, that are ordered, that kind of thing. And there's a bunch in there already pre-built. And procedure performed is a very common one. You can enter all sorts of procedures that were performed by your practice or within the group, and ultimately end up with a more complicated or detailed list of patients that you can dive into and work with. All right. So to summarize the population health and sort of give you the big picture again, you've got the clinical quality measures optimization, where you go to the these CQMs and you track them, and you track the workflow of getting the patients in there, and of course making sure that you address the gaps in care, which is another big piece of that. And then you've got the ad hoc clinical population queries to really help you dig into your patient population and maybe isolate patients that are maybe even pre-diabetic, or patients that are significantly undercoded. There's examples where you might go in and identify patients that are on diabetic medication but aren't diagnosed with diabetes, for example. And there's numerous ways that you can highlight patients that might be that might require some additional coding to bring them to a higher level of specificity. So to summarize, value-based medicine is here to stay. We keep saying it's coming and it's moving towards that. I think it's here. It's really proving itself, and these tools have really become invaluable to really maximizing clinical workflow and clinical quality in general. I'll turn it over to Jason. Jason, do we have any other questions?
Yeah, and timely questions at that. We've got one regarding to MIPS. So touching on that point you made earlier, do you file for MIPS with the tool, and will it provide an end-to-end bonus?
Oh yeah, great question. So I didn't dive too far into that, but that is a payer program, as most know. It's a CMS program, and there's some pretty significant dollars involved in that, and it's only growing. We are indeed a CMS-approved registry. We do file for MIPS, and you do get an end-to-end bonus because one of the unique things we do, as opposed to your traditional MIPS registry where you send them claims data and then you can sort of key that in, our data comes directly from the EMR. It comes from results, vitals, all the raw data that's in your EMR. And as such, the data is not changed by human hands other than properly documented in the EMR, which is what CMS wants. And so they reward that with something called the end-to-end bonus. And you can get an extra point per MIPS measure, quality measure, up to a total of 10 points, which is a pretty good chunk.
Yeah, I think so. All right, our next one's related to your value-based comments made earlier. How can we use this tool to help with the value-based contract?
You know, in a real sense, this does provide you sort of a framework to manage the clinical quality. But to bring that down to earth to specific contracts, so there are a couple different models out there that we've wrestled with. There's sort of the MIPS model where you meet certain criteria, and if you do, you get a higher reimbursement, or you don't get a reimbursement drop. You need to participate. There's also programs such as patient-centered medical home or CPC Plus for the primary care groups, where by attaining these certifications and meeting those requirements, and a lot of it has to do with the clinical quality measures for sure, you get a higher reimbursement. And then there's other programs that are sort of sporadic, but I've worked with a few where if you meet certain criteria specifically with these measures, it might be a rolling 12-month average, or they check the measures quarterly. And then what they do is they baseline how you're performing when you begin your participation in the program. And it's interesting how they approach it. They're basically saying, okay, how are you doing now? And then they pay you depending on what tier you achieve based on your improvement percentage. Let me see if I can simplify that. So an example might be controlling high blood pressure. If you're at 50%, and they'll say, if you improve by 10%, you're going to go up to tier 1. If you improve by 5%, you go to tier 2. If you stay at 50% or better, you stay in tier 3. And the payments might be different. The per member per month payment might be different. There's a couple different ways to go about it. But it's really about tracking these measures, right? Tying them, of course, to performance. And ultimately, that performance is tied to reimbursements.
Great point. Great point. And to add to that, there's no doubt that value-based care and reimbursement mechanisms aren't coming. They're already here. So if you're not currently feeling that pain, you will at some point. So best to have a tool to help predict such an impact to your practice. Well, Jose, thank you so much for the presentation. Everyone, we are appreciative of your attendance. Hopefully we were able to shed some light on how you will be able to utilize the clinical module of this tool within your practice to help resolve any care gap issues. We touched on coding for value-based care arrangement, MIPS reporting, or any network need. We often get touched on by clinically integrated networks or IPA. So while data is king, it's obviously meaningless without market-savvy interpretation and subsequent follow-through and action. If you're interested in the financial and operational module, please look for similar presentations to register for those. So with that, again, thank you everyone, and have a great rest of your day.